Cast is now starting. All attendees are in listen-only mode.
Good afternoon, my SMS colleagues across the country and other friends and participants in our COVID-19 State Medical Society Collaborative webinar for Monday, April the 12th, 2021. It might interest all of you who've been with us for a while that this is the one-year anniversary of our webinar having featured outside speakers. It was April 14th last year, and we had our first outside live presenter to participate, and we are now at the one-year anniversary mark. I hope all of you are keeping safe and staying well, and hopefully as they become available, getting your vaccinations, and that your friends and family are also getting vaccinated as well. Tom, I'm going to turn it over to you to get us rolling.
Well, thank you, and we appreciate everyone's participation during this very difficult year this year. So first, I'd like to just go through if you can go to the next slide, just go through the agenda. We're going to be talking about mass vaccinations. We have Dave Thomas, who's the CEO of the Arizona State University Research Enterprise, who's been doing who's coordinated now over almost a million vaccinations. We'll also have an update, a brief update on the antibody therapies. There's some new data that's come out in the last 3 or 4 weeks that we wanted to let you be aware of, in a program that we'll be launching starting in early May, but we'll be sending over the paperwork this week on COVID antibody therapies and treating at-risk patients. In addition, and then update on resources. So if you can go to the next slide. As you know, we've been meeting since mid-March of 2020. And these are the list of the state medical societies that participated in on our weekly and now bi-weekly calls. Go to the next slide. And then good news for COVID is that the cases have leveled off about the last month and a half. It's slightly picking up, and in certain areas it's picking up greatly. But for the most part, it's been stable. And then what's interesting is that 3 weeks ago we did our last call. We were at 22% vaccination, and today we're at 36% vaccination rate of at least one dose of vaccine in the population. So it's been a tremendous increase in just 21 days of vaccinations in the country. Go to the next slide. So I'm going to have Dave Thomas, just to introduce you. Dave is the CEO of the Arizona State University Research Enterprise called Assure. And he's also the executive director of the Milo Institute. Now, Assure serves as a boundary organization designed to translate ASU's innovations into solutions addressing challenges faced by government, commercial, and international partners. And the Milo Institute is dedicated to making deep space missions affordable and accessible to universities and space agencies around the world. He has 25 years of experience in building sustainable science and technology organizations, and for the defense and academic institutions, and prior to his role as CEO, Thomas managed strategic programs for ASU and entrepreneurial programs for the defense sector. Since the beginning of COVID-19, Thomas has supervised the coordinated the organization of testing sites and mass vaccination centers throughout the state of Arizona. In early March, Arizona centers had vaccinated 360,000 individuals, at that time more than the country of Ireland. Today, he's done about 900,000, which is actually more than Nigeria or the Philippines. So we'd just like to introduce Thomas. He's David, he's a great resource. And Dave, take it away.
Thank you, Tom. I appreciate the introduction, and I really appreciate what you're doing here to provide an opportunity for people who are interested in understanding sort of what's happening in our world in this area. This is certainly the perhaps one of the greatest challenges of our time, and so I really applaud what you're doing. And so if we could go to the next slide, please. I'm actually joining you from our 4th mass vaccination site in the state of Arizona. It's just been a real honor to serve our community and to work with the state. We are partnered with Arizona Department of Health Services, the Department of Emergency and Military Affairs, and just a whole host of vendors and others, and really just kind of want to share the journey. And so I'll start with just a little bit about, how in the world did an academic organization get involved in this, and how do we provide operations at scale for a response to COVID, and then go into, really the start of things, just a slide on testing, and then get into the meat of the conversation around how we've approached vaccination sites. We now are executing 4 different models as well, so it might be of interest to your audience to just hear a little bit about some of the attempts that we've made at efficiency, some of the trials we've struggled through, and some of the successes. So very grateful to be a part of this. Next slide, please. So Tom did a wonderful job talking about Assure. ASU has recognized that in academic ecosystem, there is, just this tremendous, sort of fount of innovation that it is the faculty and students, as well as laboratories, institutes, academic units. And there is a need for structures, organizational structures that help that innovation make it into society. And so that's what Assure is all about. We are positioned alongside ASU as an implementation partner. We provide operations, we provide specialty organizations like institutes that are serving a specific mission. And so we provide those structures, and our goal, our objective is to really leverage our ability to deploy ASU's innovation to tackle the big challenges of our time, and certainly COVID fits that. So we have a few business units, one of which is the Milo Space Science Institute that you've mentioned earlier. And so we really are about impact. How we want to know, how much impact can an academic ecosystem make on the planet. So that's our Assure in a nutshell. Next slide, please. The business unit that has really provided the capacity for COVID response is our Assure Enterprise Lab, and it's basically a large-scale operations arm. We have a number of folks that have experience in the defense sector, so we bring a level of discipline and rigor to operations, and we're able to deploy at scale. Next slide, please. So I really want to start, this whole story really starts with testing. And the reason I say that is because in the process of developing the process or developing the operational construct for testing, we learned so much. We learned about throughput, we learned about efficiencies. How do we get many people tested on a site? How do we operationally attempt to test the state on a consistent basis, or a significant portion of the state? And then we also developed a real trust relationship with agencies. And I think that's really key, because that trust relationship, when it came time for us to roll out vaccination, they came to us and said, we really like working with you. We try to execute at the highest levels of integrity. And I think that really paid off quite well when it came time to then roll out the vaccination. So I'm going to start with the testing piece and just kind of give you a short history there. So next slide, please. As the quote said earlier, one of the things we realized when we started the testing process is you can't Google this. There's no playbook that we can look up and say, if we all remember back a little more than a year ago, we started in late March, early April, and we received the call from ASU that said, hey, we have a utility company here that wants to test the people in the control center at the nuclear power plant, and we don't really know how to deploy this. And so it was quite an interesting challenge and this was not unique to our situation, of course. Everybody in the country was doing the same thing. And so we pulled together some of our brightest minds. We partnered with the Arizona State University Biodesign Institute. We rolled out the NP swab in early April, in fact, the first week of April, and we were doing that for a few weeks. We were in very close communication with the Biodesign Institute, and we said, hey, this NP swab is really, really uncomfortable. We need to come up with a better solution. Their scientists, in a matter of days or a minimal number of weeks, actually came up with a saliva-based COVID-19 test. had 3 genetic markers, and it was extraordinarily effective. We were, I think, the second or third university to deploy the saliva-based test in the country. It sped up the process. It was comfortable. We had turnaround times less than 48 hours. And so the state asked us to deploy this across the state. Next slide, please. In the process, we began scaling up pipeline. We knew we needed clinicians. We were very fortunate to be able to leverage the Arizona State University School of Nursing and Health Innovation. We have an EMS school. We have nurses and doctors who are giving of their time. And so we were started with our own resource pool and quickly outpaced our ability to staff the sites with RNs, MAs, CNAs. And so we then started reaching out to staffing agencies and building up our pipeline. One of the key partnerships was with the utility, APS, and the photo in the upper right there is actually on their what's called the Four Corners Power Plant, actually located on the Navajo Nation. As many of you know from the headlines, the Navajo Nation was hit really, really hard by COVID. There's just not a social definition for distancing in the culture of the Navajo Nation. And so you have people that are housed in close proximity to each other. There's a sort of shockingly high number of people that don't have running water, so they weren't able to wash their hands and as often. And so we had an incident rate of COVID that was 9 times higher on the Navajo Nation than the rest of the state. So we really wanted to try and help where we could there. And so we worked closely with APS. We developed a testing site that was literally built from scaffolding and plastic. And we had a drive-through site. We pioneered the saliva-based testing here at this location. And it was just extraordinary how people came together to provide an advanced technique in a population that was really deserving of it. Next slide, please. We saw people literally running to the front lines. We saw people from events, and as I already mentioned, certainly the medical, but also non-medical vocations and schools. The Watts College of Public Service was sending people from their leadership school, and we had social workers. We had, people whose day jobs were sort of decimated, and everybody just pitched in. It was really an extraordinary experience. One of the things that we saw as well was when the saliva kicked in, it's not an aerosolizing event, so we don't have to use as much PPE, and we saw the supply or the demand for PPE drop pretty significantly. Next slide, please. So that is sort of a background to what we're doing now in the vaccination. We received a call on January 5th from the state saying, hey, can you work with us? We'd like to roll out a mass vaccination site, and we would like for it to be a 24/7 operation. So our very first site was a 24/7 operation at State Farm Stadium. And after a few weeks of really working on our efficiencies, we were able to process about 10,000 people a day. And so it was just an extraordinary experience to see this launch. Next slide, please. Since that time, we've seen the second dose appointments kick in. We've are now operating 4 sites, and the state's operating other sites in addition to the ones that we are providing operational support for. And so, however, the sites that are led by ASU are predominant in the Arizona system. Next slide, please. State Farm Stadium, as I mentioned, was a 24/7 operation. We decided to go with 3 shifts, and we broke it down into the staffing plan into paid staff, which take care of mission critical operations. And so that includes all of our clinicians that are doing the vaccinations. We also have RNs that are in what we call observation. And then we have quite a few volunteers. We were running at about a 60-40 ratio, 60% volunteer staff to 40% paid, so that we have, and that paid staff really provided that continuity of know-how from one shift to the next. And I'll walk through our process in a few minutes, just kind of describe how we were able to flow the patients through the site. As I mentioned before, the site was averaging up until recently about 10,000 people a day. Our maximum number was at about 12,000 people in one day. And because we're in Phoenix, we're already seeing some very warm temperatures. In fact, the temperatures in April were getting into the upper 90s, and this just becomes extremely challenging for personnel. It also raises safety issues for not just the patients, but the personnel working the site, the staff, and the volunteers. We have been working vigorously over the last few weeks to identify indoor sites where we can take the mass vaccination model inside large arenas in particular, but we have some other hybrid model that we'll show here in just a few minutes. For State Farm Stadium, we're going to be transitioning it later this month into an indoor arena. But because the temperatures are already so high, the state decided to go ahead and suspend the 24/7 operation and go to nights only. So this is now an overnight site. We're running from 7 p.m. until from 5 p.m. until 10 a.m. So we've had to cut the throughput down, but really it's done wonders for personnel because they're not out on the pavement in the heat of the day. We have the state's partnered with Walgreens for pharmacy at this location. We partnered with Walmart pharmacy at other locations, and these relationships, these partnerships have been just extraordinarily valuable. Next slide, please. So this site, because of the numbers that we were seeing, Tom mentioned the fact that when we spoke a month or so ago to prepare for this meeting, I was citing our numbers, and at the time we were ahead of like 80 nations just at the State Farm Stadium alone. It was an extraordinarily, and still is, an extraordinarily efficient process. Our wait times were on average around 35, 36 minutes. So this is comparable to a clinic visit. And the numbers are such that I don't think there's any clinic, that could really process those numbers. So it was just we started getting a lot of recognition. And President Biden actually and Vice President Harris did a virtual tour. The lady in the center of the screen is Brittany Hayes. She was with us during testing, and I handpicked her for her ability to adapt and just her dedication to this process. I asked Brittany, I said, when we were asked to start the vaccination process, would you come join and be our lead charge nurse and help us develop the processes for vaccination? And she said, David, I'm in the middle of my master's, but I think I would like to delay my master's. And I tried to discourage her. I said, I don't think that's a good idea. I said, your education is extraordinarily important. I really think you should continue on. And her response to me is really telling. She said, David, I don't know that I'll ever do anything this important in my career. And that's been the sentiment that we've seen from nurses, from lay people. We have people that are volunteering on a consistent basis just over and over again. And the nurses that we're seeing, in fact, I heard recently that some of the nurses are preferentially coming to our site over their day jobs at the hospitals that are in our region. And so that just sort of is a testament to, I think, a positive culture that we tried to create, a real opportunity to be a part of the solution, and people are resonating with that. We tried to, in this briefing to the president and vice president, really articulate what I would consider to be the I guess most prominent reaction that we see, and I would call it hope. What we see on the faces of individuals is, the fact that now that they have their vaccine, they can think about travel, they can think about visiting family. There's this renewed sense of hope that my life is going to be something along the lines of normalcy in the near term. And so that message was given to the president. He ended up repeating it many times, and Brittany said, we're giving a dose of hope. And so that was sort of, he caught on to that. But we see that all over. Next slide, please. We post the some of the social media that we're finding on boards around the site just to encourage our workers, and we see this common theme around efficiency, and we've seen words in social media like runs like a Swiss watch, and so it's just truly rewarding. It's not to say that we haven't had our challenges. We certainly have. We've had some messaging that was sent out that sent the wrong message. We've had our call center provide incorrect information, and so we've had to work through challenges where our wait times exceeded, but on what we were expecting. But on the whole, again, an average of 30, 35, 36 minutes is the wait time through the system. Next slide, please. So we've commissioned a person to go around and sort of write the stories. We want to capture this because we think it's a very interesting moment in time, and we really want to hear from the staff, the volunteers, the patients, the vendors. I mean, there's stories of people who were, facing bankruptcy, vendors, and we were able to give jobs. There's one of the things that I've tried to do is to reach out to at least and make sure that we have at least one minority-owned company at every site that's providing services, and we've maintained that. Somewhat surprisingly, one of the common themes that we heard is that the volunteers so enjoy doing this that there's stories of spontaneous dancing that sort of erupt, and we think this is sort of a neat thing that people are actually really that happy that they're kind of enjoying this opportunity to give back to their communities. Next slide, please. I'm going to spend just a few minutes to talk about some of the designs that we're implementing and give a little bit more of some of the background on how we're executing this, and then I'll hand it back to Tom for Q&A. So I'll start with the drive-through model. This is, next slide, please. This is the one that we started with because we believed that the vehicle offered additional safety for those workers who are working on the site. The cabin of the vehicle actually serves as an isolation chamber. We would roll down, just a window at a time until vaccination, and we would ask the vehicles to roll down all windows. Just a quick walkthrough of our process. Patients would enter, in this case, from the bottom entryway. We have a patient check-in area where we're asking if the individual has an appointment. If they do not have an appointment, they're diverted to the left where we have sort of a TLC area or a registration zone labeled number 10 on this slide. And there we actually assist in creating appointments. And we do this because it's a bit of it can be a time-consuming process. And so we remove that time-consuming process out of the critical pathway. For those patients who do have an appointment, they're proceeding into what we call the clinical pathway that starts with our Zone 5 data verification. There we basically treat the patient as if they were entering a clinic. So the first thing that happens when you do enter a doctor's office is you'll go to a counter and someone will make sure that all the information is accurate in the system. Your date of birth is correct, your name is correct. Here we are asking questions about risk factors for reaction to the vaccine, whether or not they've had anaphylaxis or are allergic to medications. We ask if they own an EpiPen. The method that we've used, if an individual is at risk for any of those factors, we'll tie a stretch of safety ribbon to the mirror on the side of the vehicle, and that alerts clinicians and the rest of the process that there is someone in that vehicle who is at risk for a reaction. So they're trained to pay special attention to those individuals. Once the data is verified, the individuals will queue into the vaccination zone. We have these tents, lanes of tents, structures that provide shade for the clinicians. They receive their vaccination, and then they'll queue into an observation zone. There at observation, we're observing the individuals for 15 minutes. If they have that safety ribbon tied to their mirror, then we'll observe for another 15 to 30 minutes total, and then they'll exit the premises. In the process, we're also signing individuals up for their second dose. In the observation lanes, we're using iPads so our volunteers and staff can walk the lines and engage the patients, make sure that they do have that second dose so that everybody leaves with that second dose appointment. In all cases, we have found that it's really advantageous to have pharmacy located in close proximity to the site. So here at Phoenix Municipal Stadium, the pharmacy was located actually in the VIP box in the baseball stadium. So had quite a nice view for the pharmacists who are drawing the syringes. Next slide, please. This one got distorted a little bit, sorry about that, but this is an arena model, and this is the standard arena that is in many cities. This is where our basketball team plays, Arizona State University basketball team, and the way that we have designed the flow is on the northern side of the arena. Individuals will enter, they're greeted, the patient check-in occurs there at bistro tables. We have a fun and sort of friendly atmosphere, very friendly atmosphere, where we're verifying the data. They can proceed either to the east or the west. We have a symmetric design, and patients will enter either side. Well, they will enter like a booth that is created with pipe and drape. It provides privacy. At that point, the vaccine will be delivered by RNs. They then proceed into the arena at the concourse level. They'll sit in the arena. We have a visual on the big screen. We have the time up so that they know when they're ready to depart. We have nurses that are stationed throughout the bleacher seats where the individuals are seated to make sure that there's no reaction. We have our ambulance staff up on the concourse level, and so it's a very comfortable place to rest. Obviously, this one is indoors, so this is all in air conditioning, which is in Phoenix quite important. And today was day one for this site, and right now we're operating at a throughput of about 22 minutes per patient. So very efficient flow of individuals, and we're quite excited that we're able to move the previous design, the Phoenix Municipal Stadium design, inside to get out of the heat, which of course will help with safety for everyone involved. On the southern half of the arena, we have our pharmacy, we have a hospitality area for patients, and for staff and volunteers. We have our operations area there, and our supplies are all located in rooms to the south. This creates a very nice compact design. Everything is on one level. We're all located on the concourse level, and so this is, I believe, going to be a very good model. Next slide, please. We do have another walkthrough model that we've created in partnership with the Yuma Regional Medical Center at the Yuma Civic Center. Actually, the medical center started this as their own vaccination site, and it was just incredibly effective. This was just an amazing team, and really, when we went to Yuma County to look for locations to set up a state-run site, we were so impressed with this team. We just decided to support them in whatever way we could, because they were already doing such an amazing job. I will mention that the CDC published an article about 2, maybe 3 weeks ago and listed Arizona as the number 3 in the country for vaccinating underserved populations. So, and Arizona is one of only 2 states where our vaccination rate for vulnerable populations is actually higher than non-vulnerable populations. And so we're very proud of the fact that we've been conscientious and intentional about reaching out to, communicating with vulnerable populations, and this is one site that's really made a difference and made an impact in our communities. So again, it's through these partnerships, it's through working together as one unit, one team, even though we have different home offices. When we come together to vaccinate, it's just an amazing experience to see the unity that is different organizations coming together for a single purpose, and that is to help out our communities. Next slide, please. Lastly, we have a hybrid model. This is one where a company actually very graciously donated the use of a very large warehouse. And we call this a hybrid model because it is indoors, but we actually have vehicles driving through the facility. So this is a distribution center. It's in the latter stages of construction. They've given us a portion that's completed where vehicles drive into the distribution center. We process them as we would in an outdoor site, with the added advantage, of course, that this is in air conditioning. And so everyone is inside. We have a very large HVAC system. We have fans. We have CO2 monitors, making sure that the air is clean and is exchanged on a consistent basis. And next slide, please. So it's just been a true honor to be in a place where we could contribute our know-how, our resources, and come together as a unified team and unified program. There's so many entities that are involved in this, so many organizations that are contributing. We now have a pipeline that exceeds over 2,000 people. We have 10 staffing agencies on contract. We have vendors. We have security services. We have, so many different organizations that we really need to thank. And I don't know that anyone will ever know the detail and the effort that's gone on behind the scenes from so many people to really address the challenge of this time and come together as a community to provide the solution. So, Tom, again, thank you so much for this opportunity to share with your audience. I really applaud what you're doing and just really appreciate this time. And I'll turn it back to you. Thank you very much.
Well, thank you so much, Dave. That was great. Just outline of what you're doing there in Arizona. Just a couple questions is one, you mentioned about underserved populations. In one of our previous conversations, you mentioned that you were bringing in taxis and helping people fill out forms. I was just curious how you're doing that.
Yeah, there's a multi-pronged approach to reach the vulnerable population. The taxi program is one that was piloted and it had modest success. We have created what we call, the TLC zone, and if anybody arrives that does not have a vehicle, maybe they've Ubered over or they're coming over on light rail, we have golf carts, and we'll actually pick them up in the golf cart and we'll translate them through the process as if they were in a vehicle. So we do take walk-ins, we do take walk-ups, if you will. We provide for those people. We're really interested in supporting organizations that are also doing sort of pop-up sites in the community and taking the vaccine to the population as well. It's, obviously there's efficiencies in these large sites, and so we're in the process of working with the state to leverage the pharmacies where we can then distribute into communities. So I think there's going to be another, series of models that we're going to observe and see what works best. And there are a lot of people that are working in this direction.
Now, Frank, we have a question from Terry. Do you want to read that?
Yeah, sure. Terry, by the way, David, is with the Arizona Medical Society. So she starts out by saying, "Thank you from a fellow Arizonian. How do you see your efforts changing to reach those with economic barriers into the stadium model?"
Yeah, that's a great question. And, we recognize that there's a limitation here, right? And that's mobility. So how do we address those that don't have access to mobility? So one of the reasons we opened at Desert Financial is access to light rail. The light rail actually goes right to the southern entrance of the arena, but we're also working on a mobile unit that will be able to take vaccine into underserved communities, vulnerable populations, those that don't have mobility. We've had meetings with civic leaders as well as business leaders, and we're assembling that as we speak. There are also some organizations that are already doing this. We're partnered with, have partnered in the past with Dignity Health. Dignity is doing this as we speak, having sort of pop-up sites. We are keenly interested in working with folks like Yuma Regional Medical Center, who has just a tremendous outreach program, and they have relationships with people in these communities. So it's going to be ongoing. I think this is certainly an area of focus for my organization, myself. We're putting energy into this. We believe that we must do better at reaching out by taking the vaccine to the community, so that it's not just asking them to come to us, we're going to them. So great question, certainly a lot of work in progress, and look forward to being able to report out on more details soon.
Thank you.
David, as a follow-up to that question, have you approached the National Guard? I know some states have partnered with the National Guard on the vaccination clinics, as well as establishing the mobile units that go out into the community.
Indeed, the National Guard is integral to this process. You know, we're partnered with ADHS and Arizona Department of Health Services, as well as DEMA, Department of Emergency and Military Affairs. The National Guard is affiliated with DEMA. And so we work very closely with the state surgeon. In fact, I look to our state surgeon as sort of our, chief medical officer, if you will, for these sites. We engage with them regularly. In fact, at the sites, the Guard act as our couriers. So they transfer the vaccine from pharmacy to the vaccination areas. We've worked alongside the Guard on testing, as well as providing vaccination across these sites. Very integral to the process. They've been extraordinary to work with. I can't say enough good about and the experience of working with the Guard in Arizona.
Just one final follow-up question. If a state medical society wants to work with a mass vaccination site to let their members know that that you guys exist, and how to get their patients to sign up, what do you recommend in that respect? What communications do you recommend?
So the state controls the sign-up process, the portal, if you will, for the appointments, and so that's not something that we have control over. There is a regular release of new appointments, and those are basically defined by the state based on the anticipated flow of vaccine into the area. So that's not something that we necessarily have control over. Certainly on the volunteer side, all of our volunteers receive vaccine at the end of their shift, and we're working with a really wonderful organization to provide an electronic sign-up process. The name of that organization is called Hands On Greater Phoenix, and so there's many opportunities to volunteer as an organization or as a team, as a club or group, and we will provide that vaccine at the end of the site. Also, for clinicians who would like to serve, that's a good way to sign up as a clinician. And then anyone can always reach out to me if there's another avenue that you would like to attempt to pursue.
Well, thank you very much, Dave. We appreciate you joining us today, and I'm hoping to schedule a trip out there to see you in the next month. So thanks so much for joining our call today.
Thank you very much.
We have a request came in between meetings from Regeneron. Wendy Campman is their executive medical director. Go ahead to the next slide. And she's executive medical director at Regeneron, and she's leading Regeneron's medical affairs efforts for COVID-19 antibody therapy. Prior to joining Regeneron, she has experience working with BMS, AbbVie, Abbott, in all in medical affairs and scientific research related roles. Wendy has, in addition to that, we will be rolling out to the coalition, to the collaboration this week, information on a new series that we'll be working with 47 hospital-based education programs on COVID-19. So Wendy, I'm going to hand it over to you.
Thank you so much, Tom. Can you hear me well?
Yeah, you sound great.
Perfect. Very good. So thanks first and foremost for having us present to you again, and this time on brief updates on REGEN-COV, casirivimab, and imdevimab. It's been an amazing week and actually an amazing couple of weeks, and I'm very happy to share some of these updates with you. Next slide, please. And this is our usual legal notice, which we can quickly skip over. Next slide, please. So as many of you hopefully have seen, the NIH has updated their COVID-19 treatment guidelines last week on April 8th, strongly recommending bamlanivimab plus etesivimab or casirivimab plus imdevimab in outpatients with mild to moderate COVID-19 who are at risk of disease progression. I'm hopeful that these guidelines will help with implementation of appropriate protocols across the United States. Their recommendation is to start treatment as soon as possible after a patient tests positive. In the absence of comparative clinical data, the NIH is pointing out that variants can carry the A484K mutation and that this mutation can reduce susceptibility of bamlanivimab as well as etesivimab and casirivimab, albeit to a lesser extent than the reduction seen for bamlanivimab by itself. And I'll just show you a table on the next slide. Hence, some panel members of the NIH would recommend in regions where these variants are frequent to preferentially use casirivimab and imdevimab. So this slide highlights the reduction in susceptibility seen in the different approved monoclonal antibodies across the variants of clinical concerns. And in yellow, you can see the E484K variant playing a role in the South African, Brazil, and New York variant. And to the right, you can see the fold reduction in susceptibility of bamlanivimab monotherapy, and then next to it, bam plus eti in the middle, and then REGEN-COV to the left, with no change in fold reduction in susceptibility observed in the non-clinical in vitro setting. Next slide, please. So going from preclinical to clinical data, this is a quick overview of the REGEN-COV development program and where we are at right now. So you might have seen the the press release issued earlier this morning, sharing outcomes of the phase 3 2069 prevention trial in household contexts with a high risk exposure to COVID, demonstrating a 81% reduction of risk of symptomatic SARS-CoV-2 infections with subcutaneous administration of REGEN-COV, as well as a significantly reduced progression to symptomatic COVID-19 in patients who were recently infected but asymptomatic. And the study results that were released this morning speak about the 2069 data. So you can see them all the way to the left. This is really done in the prevention setting before getting infected, or as the second press release spoke about, just being infected and preventing symptomatic disease. So really being on the bridge of being pre-infection and post-infection. Then there is a study called the 2067 study in outpatients that read out around 2 weeks ago, the phase 3 study, with results of the 2 IV doses, both the current EUA approved dose of 2.4 gram, as well as the 1.2 gram dose in the outpatient treatment setting, as I mentioned. So at the same time, we also read out the phase 2 part of the 20145 study, and this is a study that looks at different doses and forms of administration of REGEN-COV. And then lastly, the 2066 study is studying hospitalized patients, and that's still ongoing. And in the same setting, we also have a large trial ongoing in the United Kingdom that Regeneron is supporting with drug supply, called the recovery study. So the last study to mention, there is a multi-dose study ongoing to characterize PK and safety of repeated doses in healthy volunteers. Next slide, please. And as I mentioned before, if you've seen the press release of this morning of the prevention study data, then the imminent question might have come up. And as we've seen the previous presentation, so nicely speaking about the role of vaccines and how to actually implement them. So what about vaccines and where did they sit next to one another or in complement of one another? So the government has focused, and rightfully so, their efforts on COVID vaccines to protect the entire population, really, but those who have not yet had COVID. So right now, around 1/3 of the US population has received their first vaccine dose, and around 1/5 has been fully vaccinated. This will, of course, increase and hopefully as quickly as possible. So right now also, we see an increasing number of new cases around the country. Only yesterday, there were 68,000 new cases reported per day, despite vaccine rollout, with an increase in variants, mainly the UK variant in the United States right now. So what do we do with patients who have not yet been vaccinated and are at high risk to develop severe disease and then get COVID? It's too late, really, for a vaccine. And we know that giving them monoclonal antibodies reduces their chance of hospitalization, at least as demonstrated by REGEN-COV, chance of hospitalization or death by 70%. And I will show you the data shortly. So people who need immediate protection and are at high risk to develop severe disease, they should really receive monoclonal antibodies as soon as possible after diagnosis, as per EUA within 10 days of receiving the positive diagnosis, but ideally as soon as possible as per NIH guidelines. In light of the new data, monoclonal antibodies should not replace vaccines. But what about those who don't respond to vaccines, such as the immunocompromised, don't want a vaccine or can't have a vaccine, and are at risk to develop severe COVID? We'll see what the FDA says with regards to EUA in the prevention setting, which we will submit our data for. But right now, the real need is still to treat those who are infected and are at high risk to develop severe disease, to keep them out of the hospital and reduce death. Next slide, please. So these are the data that were released in very high level in form of a press release 2 weeks ago. And we, of course, are submitting the data as well for peer-reviewed publication. The 2067 study on the left looked at reduction of hospitalization and all-cause death in over 4,500 patients, looking at 2 different doses, the 1.2 gram and the 2.4 gram IV. And both doses showed around 70% reduction in hospitalization or all-cause death. Also, both doses showed a reduction of resolutions of all symptoms from 14 to 10 days for both doses compared to placebo. From a safety perspective, serious adverse events were more frequent in the placebo group compared to regen dose groups, 4% versus 1.4%, as you can see here. There was no difference in safety profile between the 2 doses. In the study on the right, 20145, which was a phase 2 study, looked at virological reduction through day 7 of a multitude of doses in around 803 patients in total, all of whom were seronegative at baseline. So they received 300, 600, 1200, and 2400 milligrams IV, or 600 or 1200 milligrams sub-Q. There were no statistically differences observed around any of the dosing arms, so that the 2 SAEs were both assessed as not related to drug. Next slide, please. What we wanted to update you on, besides the data, which is has been a wealth of information provided, I think, to the healthcare community over the past 2 weeks, which all need to be digested, but all, I think, could really help to shift the needle as to how monoclonal antibodies are going to be used in the treatment setting, first and foremost, whilst vaccine rollout can increase. We've also heard a lot of feedback around the formulations and the presentations that REGEN-COV was provided in, and caused some confusion amongst healthcare professionals. We have now updated the formulation presentation of our antibodies, and they are available in a dose pack. So each dose pack that is available for direct ordering is available in dose packs that contain a 2.4 gram dose. And some hospitals still have individual vials perhaps sitting on the shelves, either on the smaller vials, the 6R vials, or larger vials, the 20R vials, either with clinical trial labeling and some with EUA labeling on them. If the instructions are being provided on the Regeneron website to see how precisely these vials can continue to be used to create a 2.4 gram dose in the outpatient treatment setting in IV formulation. Next slide, please. And I'll show some of these dose packs images. And you really only have to focus on the left-hand side of this slide, where we see a combination of 2 vials in a dose pack, consisting of 1 vial of casirivimab. The 20R vial is a 11.1 mil vial, and 1 vial of indevimab, 11.1 milliliters. It's also a 20R vial, or a combination of 8 vials consisting of 4 small vials of casirivimab and 4 small vials of indevimab. We've not yet rolled out dose packs on the right-hand side, which consists of a different number of vials for each of the antibodies. So really only focus on the left-hand side, having 2 or 8 vials for the respective, including both formulations of casirivimab and indevimab. Next slide, please. Another update I think that's important for the healthcare community is to know that also in line with the updates on bamlanivimab and etesevimab, there is also a possibility to infuse casirivimab with indevimab with a faster infusion rate. So it's possible to add casirivimab and indevimab to a 50 ml pre-filled 0.08 sodium chloride infusion bag with an infusion rate of 210 mL per hour to infuse over 20 minutes as a minimum infusion time, with other potentials, displayed in the table below, up to a maximum of 52 minutes for a 250 ml sodium chloride infusion bag. Next slide, please. And I think that we're all in the same boat and trying to contain the pandemic as well as we can across the different specialties. I'm a pediatrician by training, used to work in the pediatric ICU and the ER setting. And of course, I know that the majority of cases here and people that have high risk to develop severe disease fall in the elderly population and those who have concomitant comorbidities. Nevertheless, I think we all want this pandemic to get to a hold as quickly as possible, and cross fingers with the rollout of vaccines, we'll get there sooner rather than later. In the interim, to get monoclonal antibodies used in patients at high risk for severe disease and keep them out of the hospital is something that we feel on the medical affairs side at Regeneron very, very passionate about. So we are well in the process of and hoping to roll this out soon, is an educational campaign around monoclonal antibodies to really increase awareness of monoclonal antibodies in both patients as well as healthcare professionals. And we do that through different means, through TV, radio, and social media. And here you can see some of the details around what we're aiming to achieve here and the resources that we are putting in place to ensure that there is increased awareness of monoclonal antibodies across the country, specifically focusing on areas, as you can see on the slide, on the bottom of the slide here. We also make these tools available, most of these tools available in both English as well as in Spanish. They will all direct to a website where additional information is available that's led by the government or an independent medical educational resource. I will be happy to provide additional details if there is interest in this. Next slide, please. So we've also developed a couple of tools that we've heard from the field were helpful to have, such as a decision tree to really decide within your hospital, within a hospital setting, who is eligible for monoclonal antibodies, taking physicians down a decision tree to see which patient could be eligible for monoclonal antibodies. Next slide, please. We also provide infographics on COVID-19 and the role of monoclonal antibodies directed to patients, and we're happy to provide that to anyone who's interested too. Next slide, please. Also, efficacy versus variants, against variants and versus other antibodies. I think across the spectrum of monoclonal antibodies, it's important to know where you live, where the variants are, and which antibody therapies could be most effective in the region that you live in. So we've developed this piece for our healthcare professionals to guide them through the decision-making of which antibody cocktail to use. Next slide, please. And then there's the role of vaccines and monoclonal antibodies. I know that there is still a lot of uncertainty, and I don't think that the press release this morning has helped to clarify that vague distinction between how can monoclonal antibodies be used and where's the role of vaccines. But there is a clear distinction as to how both can be used. We developed this piece for healthcare professionals to make it clearer as to what the additional role of monoclonal antibodies could be next to vaccines, which need to be on the forefront and certainly cannot be displaced by monoclonal antibodies and never should be. Next slide, please. So just in summary, I hope that that's despite the good data that we received this morning, that vaccines and monoclonal antibodies have complementary roles and both are crucial in the fight against COVID-19. I hope to have shown you that we have a wide-ranging clinical development program and that covers the disease spectrum from asymptomatic prophylaxis to the more severe hospitalized patients. As you know, we've received FDA emergency use authorization in the mild to moderate COVID-19 patients at high risk for severe COVID-19 and or hospitalization. We've demonstrated that REGEN-COV retains neutralization ability against all current clinical variants of concern tested, that we have developed dose packs, and also that infusion times have been updated, hopefully to provide easier use in the practical setting in hospitals and infusion sites, and that we very much remain committed to provide additional educational tools for healthcare providers and for patients to increase the appropriate use of monoclonal antibodies to combat COVID-19. Thanks very much, Tom.
Yes, thank you so much for that great update presentation. We're all looking forward to learning more about and educating around this issue. I see you have your list of resources here. Very important that everyone learn as much as we can and just disseminate. If any of your physicians at your states are interested, that's a way of them disseminating and getting information. I recently had helped several people get through the locator find antibody treatment, and they were able to work with their doctor to get it, and it was a game changer. The next day they were fine. So all their symptoms had resolved. And I'm not saying that works for every patient, but the ones that I've worked with have. So I recommend highly. You'll be hearing more about it. So thank you very much for your update today, and looking forward to. And if anyone has any questions, just send them over in an email. We'll be glad to forward them on to Wendy, and her answer forwarded on to the rest of the group. So thank you very much. Thanks for joining us today, Wendy. Just so you know, a couple things coming up. This Thursday is a special topic program from the California Medical Association. They've recently, to meet state laws, have come out with some proposed standards for their CME program on cultural and linguistic competency and unintentional bias. And so we encourage you to participate in that this week. If you go to the next piece, coming up on Thursday, also Thursday this week, if we have one more prostate cancer program for COVID-19 that will be available. Go ahead to the next slide. And this week you'll be receiving communication from us on high-risk patients to manage high-risk agents with COVID-19, outpatient management to prevent progression. This is a hospital-based series, so we're asking you to, and we have funds set aside for state medical societies to promote this to your hospitals, and also to advertise these webinars to your members. In all, there'll be about 47 of these webinars, and contracts will be coming out this week. that you will be receiving. We're hoping to start the first meeting May 2021. We have one hospital already signed up for May 27th, but we're hoping that we can even get that going sooner because we realize the need for these programs is so important. Go to the next slide. And we have these online courses available. So if your state is not doing these, there is still some funding left to help promote these. So please let us know if you're interested in signing up. Go to the next slide. And we're also going after a couple additional grants, including vaccine hesitancy. So just be prepared that you may be receiving some information on that as well. Go to the next slide. And also we have resources available. This will be archived up on the State Medical Society Collaborative website. You're welcome to download it, and the recording is there, your slides. If you have any trouble downloading or getting recording, let us know, and we'll make sure we send you a direct link to those. They're all posted on YouTube as well. Anything else, Frank? You're trying to try to 4?
Nope, Tom. I think that's that covers it and brings us up to the end of our webinar. Just a note about the special session coming this Thursday. I did send out links to registration. So check that email. That went out last week. I'll send another probably tomorrow or Wednesday with a repeat of that information so that everybody gets an opportunity to register for it.
Also, one other thing is that if you go to the next slide, the next meeting we're having state medical societies present about what they're doing for mental health. We have the Pennsylvania Medical Societies already sent over their slides, but if you would like to participate in just kind of best practices for mental health, we really need help. I'm sorry, I didn't mean to cut you off on that one, but
no, it's okay.
We really need some additional medical societies. We've reached out to several are still considering it, but we really want to see what resources are your state offering in the mental health resources to your members that other states could benefit by knowing this is available and can repeat your practices for them. I on a personal level, I had a cousin who was on 9/11, was served through the whole thing, and 16 years later took his life. And so it's to me very important that mental health resources are available to medical society members who are especially on the front lines of this. So go ahead, Frank.
No, that's great, Tom. No, good reminder. And if others out there have programs that they would like to share, please contact Tom and I and let us know, and we can arrange to get you included in that presentation. Tom, do you want to point out the future programs we have scheduled coming up?
So after that, we're looking at vaccine hesitancy, a little bit about viral vector vaccines, long COVID, how do you deal with the complications, and COVID strains, which apparently strains are becoming even a new issue. So look for more and more. Just when you think you're just about done, there's plenty more to talk about. So.
Okay.
And again, if you have someone that knows some of these topics that's in your state that you think should be moved to the top, we have speakers, but we'll be glad to share the podium with those individuals.
All right. Tom, anything else you want to add?
No, thank you.
All right. My dear colleagues, please stay safe over the next 2 weeks. Remember, we're doing this every other week now, not weekly as we were before. Any suggestions that you might have, please share with Tom and I, because we're always open to adapting, changing, and growing to make this as effective as it possibly can be. Otherwise, please stay safe and stay well, and we'll see you in 2 weeks.